Thank you very much, Pablo, for the invitation. And there are some news because I just moved to another university. Now I'm living and working in Lille, in northern France, but still France. So the basic goal in the treatment of DDH, as we have been discussing today, is to maintain a concentric reduction as to allow the hip to develop normally. Thanks to several natural history studies, we know that these plastic hips become around 20 years of follow-up, and that subluxation leads to the onset of osteoarthritis. On the other hand, dislocated hips tend to do a little bit better because they don't cause disability before the 5th decade, and there is variable evidence of knee and back pain, and worse long-term outcome has been shown, as you can see in this slide, for acetabulum. In this upcoming slide, we have a 16-month-old young girl with the left dislocation, and in this case, as you can see, the hip didn't remodel throughout the follow-up period, and by age 5 years, the patient had persistent acetabular dysplasia. So persistent acetabular dysplasia means that the acetabulum is shallow or vertical, and this cannot provide an inadequate coverage in order to contain the femoral head in a well-reduced position. And this abnormal edge contact loading leads to acceleration of arthritis. However, it is not really known what is the frequency of this persistent acetabular dysplasia. If we look at the literature, we have a broad range between 4.9 and 33.8%. And the lowest limit, the lower limit of persistent acetabular dysplasia is probably related to the fact that in this analysis, most hips were stable. But there are several other papers that have identified more or less a 16% risk of persistent acetabular dysplasia. And the only clear factor that has been so far identified and proven to be a risk factor for persistent acetabular dysplasia is graft type 4 hips. Another important point is that even when you have ultrasound normalization of the hip, having a normal hip at the end of the pelvic harness, for example, doesn't guarantee the development of the hip in a normal way. And these two works have clearly pointed out that about 16 to 30% of patients had persistent acetabular dysplasia, even if at the end of the treatment, the ultrasound were normal. So in patients that have failed initial treatment and have developed persistent acetabular dysplasia, pelvic osteotomy becomes the treatment option. And this strategy needs to be performed taking into account the age and the morphology of the dysplasia in order to ensure the best possible development of the hip and reduce, as I mentioned before, the risk of arthritis. So the pelvic osteotomy has as a main goal to realign the native acetabular, to increase the acetabular coverage of the femoral head, to reduce the abnormal contact factors in order to prevent from early degenerative changes and avoid early hip osteoarthritis and later arthroplasty. However, what is controversial, and this is the first variable that comes into the treatment algorithm, is when to perform the pelvic osteotomies. These are procedures usually reserved to older children. However, the type of osteotomy may change according to the age of the patient. And another important point, and this is the second variable also that has to be taken into the treatment algorithm, is that the acetabulum tend to develop for longer period compared to what was previously thought. Recent publications have shown that the acetabulum, the acetabular index and the center edge angle tend to improve over a period of 8-9 years, so up to age 8-9, if the hip is well located. Here we have this case, a young girl with the left dislocation. She was treated by closed reduction. And as you can see here, the hip and the morphology of the acetabulum developed over time. And by age 11, the hip reached normal configuration. So, and this is the third important issue, what type of pelvic osteotomy you should consider to treat a specific disease. So the most common procedure are the Pemberton, Dega, and Salter osteotomy that tend to reshape and reorient the acetabulum, particularly the Salter osteotomy. And this procedure should be performed or are better indicated in patients younger than 5 years of age. However, the literature doesn't clarify the age limit guidelines for such a procedure, but is sure that with increasing age, it's more and more difficult to achieve a correct acetabular coverage with a single cut. When the patient grows older, the other option, whether the child has open or closed cartilage, a triradiate cartilage, is performing a triple osteotomy. And this is a powerful reorienting procedure that should be reserved for children usually older than 6 years of age. And then we are dealing with pre-adolescents, adolescents, and young adults. And when considering the adolescent and the young adult population, reorienting procedure and hip preserving surgery, meaning the periacetabular osteotomy, should be performed. And this is a good procedure because it preserves the posterior column and leave intact the intrapelvic space. So this is the very first part of the algorithm that I try to summarize in this slide. This is the basic. We have open triladiate cartilage, patient younger than 5 years of age, patient older than 6 years of age, the choice of your procedure, and then you have older patient, skeletally mature, where you can perform the periacetabular osteotomy. However, the situation may become more complex because into the algorithm at this stage, you have to include the combined procedure that have been recently introduced and the salvage procedure. So when you deal with the patient older than 9 years of age and persistent acetabular dysplasia, the Pember triple procedure, as described by Xue-Min Lu, can be performed. But when you deal with adolescents and young adults, you should probably consider salvage procedure such as acetabuloplasty according to Staeli, Spizzi. There are different techniques, or Chiari osteotomies. So among the combined procedure, as I mentioned, the Pember triple is an acetabuloplasty in association with an acetabular redirectional osteotomy. And this technique, together with a femoral shortening, these radiographs belong to Xue-Min, can reshape and reorient the acetabulum. However, being a quite powerful technique, it carries the risk of creating some impingement after the surgical correction. The salvage procedure are two categories. One is the Chiari osteotomy, and the second one is the acetabuloplasty. This procedure, in my mind, should be reserved to non-concentric hip. Both can be applied. However, if you have a subluxed hip, the femoral head, you should prefer the Chiari osteotomy. Both techniques require capsular metaplasia, so your cut or your graft should be placed right on the top of the capsule and provide slightly different correction. The acetabuloplasty can provide you a more anterolateral coverage, whereas the Chiari osteotomy provides you with a true lateral coverage of a subluxated hip. So to conclude, I'm sorry my presentation got longer because there is some slow transition in between slides. I try to summarize all the concepts in this final slide. It is important to take into account when making your decision the age of the patient, the status of the triradiate cartilage, the type of reduction you could achieve with the initial treatment, whether it is concentric or not. And then, according to this parameter, you can select your osteotomy. And also, the choice of osteotomy will depend on the type of action you want to get. More redirectional osteotomy and want to correct more a deficiency anterolaterally or laterally, or if you want to more reshape the abnormal acetabulum. Thank you very much.